Hello everybody. Today we are going to discuss about multimodal neuromonitoring. Acute brain injury frequently involves the alteration of mental status. This limits the yield of the clinical neurological examination. Clinical finding may trace the shift in the cerebral physiology. This leads to delay in the detection only after catastrophic damage has set. This may be the cognitive impairment, delayed cerebral ischemia, and motor disability. Accordingly, frequent bedside examinations are deemed insufficiently for timely detection and the prevention of secondary brain injury as per International Multidisciplinary Consensus Conference on the Multimodal Monitoring in the Neurocritical Care. Examination must be coupled with the multimodal monitor along with the advanced bioinformatics tool for better outcome. So, neurophysiology goes through the dynamic changes after primary neurological injury. Multimodal monitoring assimilates the data from the multiple devices in real time. The goal is to identify such a fluctuations and indicate the need for intervention to prevent SBI like cerebral hypoperfusion or ischemia due to intracranial pressure surges, cerebral hypoxia, cerebral hypoglycemia, or excitotoxic damage due to recurrent or prolonged seizure. The proposed role for the multimodal monitoring are following: tracking, prevention, and the treatment of cascade of secondary brain injury, monitoring of patient with the impaired GCS of less than 9 or those with the intraparenchymal contusion and the subarachnoid hemorrhage, intracerebral hemorrhage brain CT, and these patients may have unreliable clinical examination. Providing an understanding of SBI related to pathophysiological mechanism to develop preventive and abortive therapies. Integration of the data from clinical examination, neuroimaging, and multimodal monitoring, which would yield patient-specific real-time picture for targeted management and prognostication. Various multimodal neuromonitoring based on the function. Cerebral flow directed techniques global physiology is ICP, CCP, local physiology is transcranial Doppler and the TD. Then cerebral autoregulation, which include global physiology, which include a pressure reactive index and the mean velocity index and oxygen reactivity index. Then cerebral micro-oxygenation directed techniques are uh, jugular venous oxygen saturation, and local physiology is this brain tissue oxygen partial pressure and near infrared spectroscopy. Then reflecting cerebral metabolism is global physiology by S100B and the neuron specific analysis. Local physiology is microdialysis imaging. Then reflecting cerebral global function is by EEG and QEEG. Then multimodal parameter commonly used measure devices and physiological ranges is intracranial pressure. Means of the monitoring is intraparenchymal monitor, intraventricular monitor. Physiological ranges is it should be less than 20 mmHg. Threshold is more than 20 to 25 mmHg. Clinical significance, it is a marker of cerebral edema and impending herniation. Then CPP, it is a physiological range should be 60 to 70 mmHg. Threshold is less than 60 mmHg. It is indirect surrogate of cerebral blood flow, guides treatment of intracranial hypertension to optimize perfusion. Then cerebral blood flow, transcranial Doppler, and then thermal diffusion probe. The mean velocity is MCA is 30 to 75 centimeter per second, ACA 20 to 75 centimeter per second, PCA 15 to 55 per centimeter per second, and Indegard ratio less than 3. TDP is 50 ml per 100 gram per minute. Threshold mean cerebral artery mean flow velocity more than 200 centimeter per second. LR ratio more than 6. Clinical significance of this is to detection of the vasospasm, delayed cerebral ischemia in SH, and differentiate hyperemia from vasospasm, indicative of regional cerebral ischemia. Then cerebral oxygenation, it is measured by jugular venous oximeter. Physiological range is 50 to 80%. Threshold is less than 50% and more than 80%. It is indicative of global ischemia and hyperemia and tissue extraction of the oxygen, and indicative of regional hypoxia and hypoperfusion. Then cerebral metabolism. Means of monitoring is microdialysis. Glucose physiological range, glucose is 0.4 to 4 micromole per liter. Threshold is less than 0.4. So it is indicative of brain energy supply and the demand. Lactate is lactate threshold. Lactate means of monitoring is 0.7 to zero point 0.3 micromole per liter. The physiological range is more than 3. Lactate to pyruvate ratio less than 20. Physiological range more than 20. Elevated LPR indicative of ischemia, anaerobic metabolism. Then glutamate range is 2 to 10. Physiological range is more than 10. Then threshold is increased glutamate and lactate are earlier marker of ischemia, followed by increased glycerol. Glycerol, the range is physiological range is 10 to 90, and physiological the glycerol range is 10 to 90. Physiological range is more than 90. Now, multimodal monitoring is the intracranial pressure. The commonest monitor parameter in acute brain injury are intracranial pressure and cerebral perfusion pressure. Acute brain injury causes large increase in intracranial volume due to cerebral edema and expanding hematoma. This causes reduced cerebral blood flow and ischemia, followed by cerebral herniation. The overall prognosis is worse. Protocol recommends ICP monitoring in acute brain injury, where clinical and imaging features suggest risk of elevated ICP. Additionally, cerebral perfusion pressure and assessment of intracranial compliance, cerebrovascular reactivity, and autoregulatory status can be monitored. Ventriculostomy using EVD remains the gold standard ICP monitor for the global ICP. Extraventricular drain is re-zeroed after placement to the minimized shift. It allows cerebrospinal fluid drainage in patients who have hydrocephalus. However, insertion in the compressed or displaced ventricle can be difficult. The fluid column can be obstructed by the blood clot, leading to the inaccurate measurement. Further, transducer should be maintained at fixed reference point relative to the patient's head. Extraventricular drain placement may cause significant clinical bleeding in less than 1% cases and EVD-related infection in 5 to 15% of cases. For traumatic brain injury, you need only ICP and CPP monitoring and are not at high risk of hydrocephalus. The intraparenchymal monitor are recommended alternative. This placement is easier and they can provide continuous monitoring compared to EVD. Piezoelectrical strain Piezoelectric strain gauge and fiber optic sensor constitute the current technology. In focal lesion with mass effect, an interhemispheric variation of more than 10 mmHg is known. Therefore, it is vital to position sensor close to the area at risk, and so is confirmation by CT imaging. Limitation of intraparenchymal monitor are the cost and no prospect of recalibration the measurement which drift with the time. With respect to the other invasive type of ICP monitoring such as subdural, subarachnoid, epidural bolt, limited accuracy and daily drift preclude their use in clinical practice. Tympanic membrane displacement to measure ICP is investigation. It evaluates how the perilymph and the CSF communicate with the perilymphatic duct. Transcranial Doppler with the pulsatility index, pupillometry, and ultrasound measurement of optic nerve sheath are other non-invasive tools. However, they are less accurate compared to the invasive monitoring. Cerebral autoregulation monitoring. Dynamic cerebral autoregulation monitoring allows the bedside calculation of optimal mean arterial pressure and optimal CPP by non-invasive and invasive method respectively. Surrogate of cerebral blood flow can be obtained by non-invasive tools such as continuous transcranial Doppler, near infrared spectroscopy, ultrasound type near infrared spectroscopy, and invasive tool like brain tissue oxygen monitor and ICP monitor. Cerebral perfusion pressure. The difference between mean arterial pressure and ICP is cerebral perfusion pressure. It corresponds to the pressure gradient that drives the cerebral blood flow, hence the oxygen and metabolite delivery. In study involving acute TBI, fatal outcome increases when cerebral perfusion pressure was below the optimal level, whereas cerebral perfusion value greatly exceeding resulted in severe disability. Thus, for the favorable outcome, one not only has to prevent hypoperfusion but also hyperperfusion by targeting optimal CPP. However, in another study, only two-thirds of patients demonstrated an optimal CPP. In other studies where management was guided by target CPP rather than ICP, the outcome has not improved. Now, index of pressure reactivity. An uninjured brain can maintain the fairly constant cerebral blood flow despite fluctuation in the CPP. This is facilitated by the varying intracerebral vessel caliber. This adaptive characteristic of the static autoregulation is reflected by pressure reactivity. Pressure reactivity measures the correlation between arterial blood pressure and ICP waves. Pressure reactivity is represented on the scale as correlation coefficient. Negative value suggests the intact autoregulation, where positive value suggests impaired autoregulation. Study shows that mortality rate in severe TBI is proportionate to the uh, positive value. Mortality has to be lower when the value is less than 0.5. Other indices of cerebral autoregulation, indices such as mean velocity index, which is based on CPP, and the autoregulatory reactivity index have not been validated yet. Now, electroencephalography. Epileptogenic derangement in acute brain injury, like elevated excitatory amino acid and neurotransmitter, may trigger seizure. Around 5% to 15% of patients can have non-convulsive status epilepticus in 5% to 20%. Patients with ICH have a seizure more often than in AIS S30 because of extravasated iron is potentially proconvulsive. Like convulsive seizure, non-convulsive seizure also lead to state of cerebral hypoxemia and elevation of intracellular calcium, oxygen-free radical, and intracellular osmolality. This leads to neuronal swelling. There is failure of ATP production and cell death. Cerebral edema and midline shift increases and eventually leads to the worst outcome. Numerous toxic metabolites like glutamate, neuron-specific enolase, lactate to pyruvate ratio are increased in the non-convulsive seizure. Follow-up MRI shows that hippocampal atrophy is seen in non-convulsive seizure. However, ironically, no adequate power trial have demonstrated the positive impact of treating non-convulsive seizure or this non-convulsive status epilepticus. In acute brain injury, clinical seizure may be in 25%, while nearly 50% of patients shows subtle clinical findings such as oral or ocular movement or gaze deviation. Thus, in comatose patient, non-convulsive seizure would go unrecognized if not by EEG monitor. The sensitivity of intermittent EEG to diagnose non-convulsive seizure in comatose patient is 50% when compared to sensitivity of more than 90% on 48-hour continuous EEG. Besides seizure, certain EEG pattern like broad repetitive slow wave correlate with the occurrence of vasospasm. This is where quantitative EEG is beneficial as it can analyze raw EEG data of several hours. It does this by deploying compressed spectral array and presents the data in the graphical form. The role of EEG in early detection of delayed cerebral ischemia in SAH is well established. As the cerebral blood flow drops, the faster frequency decreases, followed by gradual increase in the slower frequency. For detection of delayed cerebral ischemia in SAH, alpha delta ratio, power, and percent alpha variability can be utilized. Burst suppression pattern is the another poor prognostic factor. Thalamic injury in the traumatic brain injury patient is associated with the impaired percent alpha variability on the QEEG. It heralds the poor long-term outcome. Recovery of consciousness in traumatic brain injury, cerebrovascular disease, or anoxia can be expected when EEG reactivity is present. Invasive continuous EEG monitoring can identify cerebral ischemia that are not detectable by scalp electron. Although invasive electrode like subdural strip electrode or intracortical depth electrode can be placed at the bedside and their use remains to be validated. Use of continuous EEG monitoring in ICU is limited due to high cost, non-availability of the technician to apply and maintain electrodes, considerable ICU-related EEG artifact, and availability of the physician for timely interpretation of the EEG. Devices for automated seizure detection and the remote access for EEG viewing are being developed to overcome these limitations. Now, somatosensory evoke potential. Continuous somatosensory evoke potential monitoring is useful for prognostication. In post-anoxemic coma, absence of cortical somatosensory evoke potential response bilaterally portend poor outcome as does prolonged central conduction time. In SAH, the central conduction time prolongation correlate with transient neurological deficit. An added advantage is that prolongation precedes the development of such a deficit. Other evoke potential. Brainstem auditory evoke potential response is measure of pontomesencephalic integrity. Early changes in the V wave and the V latency occur in the transtentorial herniation or increased IC. Thus, brainstem compression in comatose patient in acute brain injury can be potentially monitored. Middle latency auditory evoke potential have proven to better predict favorable outcome in acute brain injury or SBI than cortical potential of SSEP. Jugular venous oxygen saturation. Assuming that arterial hemoglobin saturation and concentration remain stable and jugular venous oxygen saturation reflects difference between the cerebral oxygen supply and demand. For jugular venous oxygen saturation monitoring, a fiber optic catheter is inserted in the retrograde direction at the origin of internal jugular vein, preferably in the dominant vein. Jugular venous oxygen saturation measurement allows assessment of global oxygenation. Catheter tip at the level of bodies of C1, C2 on the lateral neck radiograph suggests the correct placement. Complications include infection, catheter misplacement, elevated ICP, thrombosis of jugular vein, pneumothorax, and the need for frequent recalibration. Another limitation is that it may miss the critical regional ischemia as it is global and the flow weighted measure. Desaturation to 10 minutes portend poor outcome in traumatic brain injury. Conversely, the jugular venous saturation above 75% represents hyperemia or infarcted tissue. Jugular venous bulb oximetry also facilitates sampling for measurement of arterial jugular venous oxygen content difference. It can be used to monitor perfusion status. Global cerebral ischemia is suspected with arterial jugular venous oxygen content difference above 9 ml per dl and hyperemia if more than 4 ml per dl. However, its accuracy has been challenged and so it may serve as supplement to ICP monitoring. Now, cerebral microdialysis. Cerebral microdialysis allows for quantification of metabolic intermediaries, substrate, and neurotransmitters like glucose, glutamate, lactate, and pyruvate. CMD catheter is comprised of the inlet and outlet that join at the semi-permeable membrane tip. A, a perfused solution which approximates the cerebrospinal fluid in composition is infused in it. This allows for the frequent sampling of the dialysis. Catheter placement for the focal brain injury is done perilegionally and for diffuse TBI in the right frontal region and in the anterior cerebral artery and middle cerebral artery watershed region or region of the vasospasm ipsilateral to the aneurysmal rupture for SH. Glucose warrants the intervention. Low interstitial glucose level indicate deficient glucose delivery. Compared to lactate alone, lactate pyruvate ratio is more specific measure of cerebral ischemia. Glutamate level elevation is seen in TBI and SH. They represent the cerebral ischemia and may herald poor outcome. Elevated glutamate level can also cause the seizure. Glycerol elevation results from excessive degradation of cell membrane phospholipid breakdown. Like glutamate, glycerol elevation also correlates with ischemia and poor outcome in TBI and SH. Cerebral microdialysis can also predict the secondary brain injury. A study of patient of aneurysm SH found that increase in the lactate glucose ratio and LPR occurred 11 to 13 hours before symptom of delayed ischemic neurological deficit developed. A study of confirming vasospasm in asymptomatic SH patient has favored CMD when compared to TCD or angiography. In severe traumatic brain injury patient, changes in the CMD occur ahead of ICP elevation. So cerebral microdialysis can also guide insulin therapy and avoid hypoglycemia by monitoring cerebral metabolism. While initiating enteral feed, CMT can also monitor cerebral glucose. Evidence suggests that neuroglycopenia in TBI patients portend poor outcome. A tightly controlled blood glucose control between 80 mg per dl and 120 mg per dl resulted in the reduction of cerebral glucose and increased mortality in severe brain injury. Cerebral microdialysis can potentially help in identifying progression of ischemic stroke, measurement of drug level like antibiotic and anticonvulsant, and may also lead to discovery of new biomarker. Limitation of CMD include time-consuming procedure of drawing the sample. Only few cubic millimeter of sample can be collected, and catheter placement influences the result. But most importantly, normal values and cutoff for various substrate are not defined to guide ongoing therapy. At base, CMT can be combined with other multimodal monitoring. Now, brain oxygenation is the surrogate of cerebral blood flow. It can delineate the tissue that is at risk of ischemia when it is used in conjugation with metabolic parameters. Modalities like positron emission tomography, MRI, or CT perfusion, and xenon CT can help in assessing brain oxygenation. However, transferring the patient requires the cumbersome logistics. And after this exercise, we obtain merely a snapshot of cerebral dynamics, not continuous data. This greatly limits their utility. Cerebral blood flow over large area of the brain can estimated by transcranial Doppler, but operator variability limits their use. Invasive probe like implanted brain tissue oxygen tension sensor also estimate cerebral blood flow, but only overestimate small region. This brain tissue oxygen tension is the product of cerebral blood flow and cerebral AV oxygen tension difference. Before implantation, the region at risk of ischemia is determined by CT and MR perfusion studies. Then microcatheter is inserted in the white matter. Despite being invasive, the PbO2 monitor shows the low rate of complication. Depth of the probe and its nearness to the area of primary injury are crucial to the normal values of PbO2. Therefore, CT verification of the placement is important. Besides placement, other factor that affects the PbO2 include CPP, hemoglobin concentration, oxygen saturation, metabolic rate, and cerebral vasospasm. So PbO2 is the adjunctive along the ICP monitoring for CPP management. Normal PbO2 ranges from 25 to 50 mmHg. In clinical setting, moderate brain ischemia, critical brain ischemia, severe brain ischemia, and cell death are represented by the PbO2 values of 15 to 25. Now, this PBTO2 of less than 20 mmHg is a recommended threshold to consider intervention. Now, regional cerebral flow metry. Flowmetry sensors provide the data on perfusion and tissue extraction. A laser Doppler flowmeter measures erythrocyte flux. It can monitor cerebral blood flow continuously in the traumatic brain injury. Currently, it remains research tool as the normal values in various physiological conditions have not been defined. Thermal diffusion flowmetry is the invasive and the quantitative method resolution of for continuous monitoring of the cerebral blood flow. This can avert and secondary brain injury as there is therapeutic window for intervention. Solid state probe with the proximal and distal thermistor combined with the distal heating element comprise the thermal diffusion flow. Probe placement is recommended in the white matter of vascular territory, which is potentially at risk of vasospasm. The probe has been used safely in patients with TBI and allows for assessment of autoregulation. However, limitation to its use are device sensitivity to positioning and its ability to measure only very small volume. Currently, its impact on the treatment to validate regular clinical use is lacking. However, xenon perfusion CT has validated thermal diffusion flow. Cerebral blood flow level below 15 ml per 100 gram per minute can reliably diagnose symptomatic vasospasm. Now, near-infrared spectroscopy. Near-infrared spectroscopy observe real-time changes in the regional cerebral oxygenation and provide information on desaturation. It is bedside and non-invasive technique. The depth of light penetration, hair follicle density, skin tone, and skin thickness influence the spatial resolution. Near-infrared spectroscopy, when combined with the systemic blood pressure and ICP monitor, can potentially assess cerebral autoregulation. In one study in traumatic brain injury cases, near-infrared spectroscopy detects 97% of desaturation, where jugular venous oximetry detected only 53%. Near-infrared spectroscopy monitoring is currently not recommended in adult TBI patients due to lack of strong evidences. Now, the recommendation as per International Multidisciplinary Conference on Multimodal Monitoring Neurocritical Care, which are endorsed by American Academy of Neurology in 2018, is given in this table. That is ICP monitoring indication in patients with acute brain injury who are at risk of elevated intracranial pressure based on clinical and imaging features, and patient with the imminent brain herniation to guide therapy. It has a strong recommendation. Then cerebral autoregulation, which is targeting CPP management goal and the prognostication in acute brain injury. Pressure reactivity has been commonly used for this purpose, but many different approaches may be equally valid. It has a weak recommendation. Then EEG, patient with the persistent and unexplained alteration of mental status, convulsive status epilepticus that does not return to baseline within 60 minutes of treatment, refractory status epilepticus, comatose patient after cardiac arrest during therapeutic hypothermia and within 24 hours of rewarming. It has strong recommendation, but patients with the aneurysmal subarachnoid hemorrhage who have unreliable neurological examination and at risk of delayed cerebral ischemia has weak recommendation. Jugular venous pulse oximetry, patient with and at risk of cerebral ischemia or hypoxia has strong recommendation. Brain tissue oxygen monitoring, patient with or at risk of cerebral ischemia or hypoxia has strong recommendation. Then cerebral microdialysis, again the patient at risk of cerebral ischemia, hypoxia, glucose deprivation has high recommendation. Then thermal diffusion flowmetry, patient with the risk of focal cerebral ischemia has weak recommendation. Then paradox is the base strip trial was conducted on patient with severe traumatic brain injury. It evaluated the treatment outcome in two groups, one based on intraparenchymal ICP monitor and other on the clinical examination and imaging. The primary outcome of the survival team impaired consciousness and functional status at 3 and 6 months and neuropsychological status at 6 months among two groups was not significantly different. Treatment based on ICP monitoring was not superior to the neurological examination and serial neuroimaging for short-term and long-term recovery in severe traumatic brain injury patients. Thus, value of clinical examination cannot be stressed enough. The ongoing Boost 2 trial is comparing the treatment of TBI based on ICP monitoring only versus ICP or brain tissue oxygen monitoring. The results are expected to shed light on effectiveness of multimodal monitoring. Intraoperative multimodal monitoring in spinal surgery is believed to be worthwhile and it may avoid development of post-operative paraplegia and quadriplegia. Although its cost effectiveness has not been qualified, the cost of multimodal monitoring does not exceed the cost of prolonged health care for neurological sequelae. Well-designed trial, great experience with multimodal monitoring, and feedback from patients will adequately answer the question of cost effectiveness. Thank you, guys.